Hi, my name's Olivia and this was me 12 years ago. I got diagnosed with absent seizures when I was 11, and before I was put on medication, I was having around over 50 a day. When I was having the absent seizures, I felt very confused, very dazed. My memory was really bad. I didn't really know what was going on. Everything around me seemed like it changed. When I was younger, this made me feel really scared. I went to an all-girls school, so we were really close-knit, and at first, I think they were very confused. They didn't really understand. I was doing a drama performance, and I walked on to where the stage was, and I had an absent seizure. I blanked out for about a minute or so. I was not aware they were happening at all. I was completely unconscious. I found Young Epilepsy, and I found that they had like a chat line you can speak to, just call up, and their information online is really specified to young people. My whole childhood has literally been seizures, doctor's appointments, what medications to take, but there's no quick fix of epilepsy, and this is why we need the funding.
Epilepsy is one of the most common chronic neurological disorders globally, affecting people of all ages. Now, you're informed that by the school teacher that your child had fits at school today. Now, is that epilepsy? Your baby is not well, has felt a little hot and suddenly has convulsions. Is that epilepsy? You may have many other questions about these conditions, like, do children get brain damaged from seizures? Can they cope and do well at school? Can they play sport, drive cars one day, get employed? Is this condition curable? Now, how would you know if a child is having epileptic seizures? And if it does happen in front of you, what would you do? International Epilepsy Day is marked on the 10th of February to raise awareness about epilepsy and the urgent need for improved treatment, better care, and greater investment in research. So today we focus on childhood epilepsy. And to help us understand this condition a little better and answer all the questions you might have, we have a panel comprised of a professor in neurology from Wits University, the Secretary of Epilepsy Awareness South Africa, and the mother of a child living with epilepsy to share her experience with us. Now you can tweet us at SABC Health Talk or simply interact with us on our Facebook page, SABC Health Talk. Sit back, relax, and learn from this bumper show coming to you just after a short break. I'm Dr. Solomon Daung, and this is Health Talk.
My name is Renel Mackenzie Lau. I'm 19, and since I was born, I've loved football. Football's my life. I was actually trying on clothes in the bathroom, and suddenly I woke up and there were two paramedics standing over me, and I had no idea what happened. I was so scared. It's hard to put into words. There were so many emotions just running through my head. I was thinking the worst, and it was just a really sad, depressing moment. I just felt like everything was ripped away from me. I just didn't feel like I could live a normal life. It's never good to bottle up all these thoughts and feelings, you know. You need someone there who's supporting you, and that's when I was lucky enough to meet Alex.
My name's Alex. I work for Young Epilepsy. I have been working for Young Epilepsy for about 10 years now. And essentially what I do is I work with young people from the ages of 10 to 18, and I just provide a lot of personal support for them.
No one understood how I was feeling, but Alex did. And he showed me that I was not alone, and there were so many young people with epilepsy. I mean, without Alex, I wouldn't have been able to have the courage to do things like this and to speak out and face up to epilepsy.
When I first met Renel, he was not in the best place. I met with his whole family, and clearly I think everyone had been a little bit sort of shaken by the diagnosis. It's a shocking thing to go through, and I think it's a shocking thing as a family to try and cope with.
Epilepsy affects you in life, with medication, with how you're feeling, You know, you might not be able to go places that you once could. I just had to find the strength just to pull myself out of it, and you know, I just wanted to show people that you can achieve your dreams. That's why I want to do like so well in my football. I flipped my epilepsy into something positive. You know, I don't see it as a burden. It's part of me. It's made me a better version of myself. It's definitely made me mentally stronger. I just want to show people that they're not alone in what they're facing. More people like me need to tell their story.
All right, so to learn more about this condition, it's a great pleasure to welcome our guest. First is Professor Girish Modi, who's a specialist neurologist and head of Department of Neurology from West University. Hi. No stranger to this show. Welcome to Health Talk, Prof.
Thank you, Dr.
All right. Very much. And then, of course, we have Alexis Minar. Alexis is Secretary of Epilepsy Awareness South Africa, but is not only here as Secretary of Epilepsy Awareness South Africa, she also has a personal story to share with us about her condition because she's living with epilepsy. Welcome to Health Talk.
Thank you so much for having me.
All right. So, Prof, let's start with you and let's go back to the basics. And let's try and define these things. I mean, epilepsy is, I think, you know, it's commonly known.
Yeah.
But let's perhaps talk about, you know, these definitions of seizures versus convulsions versus fits and what have you. What is epilepsy?
So a seizure, a fit, convulsion, one and the same thing.
Right.
What is it? It's a burst of electrical activity. We call it the brainstorm.
Right.
That occurs in people who suffer from the condition. But having said that, the first thing we do is define the seizure. So seizure is just an electrical storm in the brain.
Right.
Right? And that switches off everything and it'll manifest with certain things that we see clinically. Someone falling down, someone getting stiff, someone jerking, someone having blank spells, someone having violent myoclonic-like movements, etc. So what we see is a reflection of what's happening in the brain and in particular in a certain part of the brain. So a seizure can, for instance, and we like to describe it as being either focal or generalized.
Yeah.
So, you know, you can get a guy whose face is twitching, his thumb is twitching.
Yeah.
So it's that part of the brain where the electrical activity is happening.
All right. We're going to come back to the different types.
Sure.
But let's just talk about the prevalence. I mean, in my introduction, we know the prevalence a lot better in adults, I'd imagine. In
so
children,
almost 2 to 5% of the population will have epilepsy.
Yeah.
Childhood epilepsy is a bit smaller compared to that. So, for instance, like in the US, where they have a population of 400 million people, 3 million or so have epilepsy. So it's much lower incidence. It's also slightly different to the adult epilepsies. Because when you think about it, the childhood epilepsies, you know, the way I see it is they range from seriously benign to seriously bad.
Right.
You understand what I'm saying? Whereas we know in the adults, the epilepsies are slightly different. So if you think about it, someone with a childhood epilepsy, if you take all of them, put them into one bag, almost 2/3, 70% won't go into adulthood. So they sort of, in inverted commas, get better, right? So you have certain syndromes, certain epileptic types in childhood that are peculiar and only unique to the childhood forms.
Okay.
So they don't become adult epilepsies. Some do, but like I said, you get the very bad ones and the very simple ones, the very good ones. So we have even benign syndromes. So we talk of benign Rolandic epilepsy. We know that occurs in young children between the ages of 2 and 5. They can go on to a little later, up to early adolescence. But those don't go on to adult epilepsy. They are benign.
Okay.
Some of them are, you know, what we call reflex epilepsies, where they respond to reading or to lights or something like that.
Right.
Then you get the absence epilepsy, what we always call petit mal epilepsy. And the majority of those, the true idiopathic generalized absences, don't go into childhood, into adulthood. So,
and of all the different types, which ones are more common?
So the commonest is the benign Rolandic. It's about 15% of all childhood epilepsies. The second commonest would be the generalized absence. And then a big topic is the febrile convulsions.
I wanted to we'll come back to that because I think it's an important one for us to talk about. But Alexis, we talk about the fact that, you know, it's a commonly known condition. And your organization is about raising awareness.
Yes.
Tell us a little bit about, your organization, Epilepsy Awareness South Africa.
Epilepsy Awareness South Africa focuses mainly on bringing support to families and people, particularly adults, living with epilepsy, because I feel like adults in South Africa get overlooked. The main focus is on children, and we have a lot of support for children. But then as you move from adolescence into adulthood, neurologists become scarce, understanding becomes scarce. Finding a job is incredibly difficult that accommodates your health. So we aim to support people and their loved ones with this condition.
Right.
And we do so through support groups where people can feel comfortable sharing their stories,
Yeah.
and we share ours.
So how do you normally function? I mean, do you have functions that you host? How do you raise awareness? Do you go to schools? Do you go to...
We do school talks.
Yeah.
And last year we did the MTN Walk the Talk, which was a lot of fun. So I took my family and everybody enjoyed it. I think we did the 5-kilometer walk.
Yeah.
We also try and do events, but it depends on the public holiday or the month and when we're available.
Yeah.
Because as I say, we all have full-time jobs, so we have to
Yeah.
make sure that we're all available
Right.
at the same time.
Right.
Yeah.
How big is the organization?
There are 7 members at the moment, 7 of us that are running it. So we're still very small. We've only recently been founded, but we are accepting any volunteers who are willing to join us, anybody who's willing to share their story with the world to raise
Yeah.
awareness.
All right. Okay, that's good. We'll come back to learn a bit more about it just now. Let's come back to you about, the clinical feature. So people saying, all right, how do seizures typically present?
Yeah.
But perhaps, just before I went to Alexis, we spoke about febrile convulsions. So we need to
Okay,
also
so
just zone in.
that's an important one, because you see, you can get a febrile convulsion is some child who has a fever of more than 39 degrees and then has a seizure. Right. Now, with a febrile convulsion, we need to understand that not all febrile convulsions will go on to epilepsy. Right? So they occur between the ages of 2 to 5. Generally, you don't see them after age 5. And so when you look at the febrile convulsions, they're usually in that period in the child's life when you're getting your tonsillitis, your otitis, your ear infections, your throat infections.
Yeah.
And there are always reasons for a fever.
Yeah.
And the trick is for parents who are listening now, is whenever you get a child with a fever, bring the fever down. Don't rush to the doctor and wait and wait and wait. Bring the
Yeah.
fever down. Tepid sponging. Wet them down. Because sometimes the fevers go quite high.
Right.
And unfortunately, in a small percentage of these children, you get a convulsion or a seizure or a fit. And then it becomes a drama.
Yeah.
Now, the only problem with this to understand is that febrile convulsions are not epilepsy syndromes.
Yeah.
They can repeat themselves, and you can get it again, and then they disappear. After age 5, they disappear. The only proviso to what I'm saying is that if there's an underlying problem,
Yeah. So the
if
child
the
might
child
be sick.
has,
or-
no, I'm talking of the brain.
Okay.
If the child has got temporal lobe epilepsy,
Right.
or some congenital abnormality, or some chromosomal abnormality or something,
Right.
and the fever brings it out.
I
And
see.
those go on to proper
Okay.
epileptic
Right.
syndromes
Right.
later.
Right.
So that's important to know.
Okay.
So obviously, it's an important one, because the minute you have it, your biggest fear is, now has my child got epilepsy?
Okay.
And we need to differentiate those two.
All right, so let's talk about the typical symptoms. People know about the tonic-clonic jerks and so on. That's being the commonest.
Yeah, so the common, it's interesting, in childhood, so the general symptoms of epilepsy, we know it's the one where you drop, which we call atonic, right? Or the one where you go blank, which we call absence. And then the stiffness is the tonic, the jerking is clonic, and then when you're getting both, you call it the tonic-clonic, right? In children, we must remember that the symptoms can be very subtle.
Right.
Okay, so blank spells, the absences are very common. So all that happens is 1 or 2 seconds, blink, blink, they're gone, they're back. Maybe if it's atypical, it's longer. Sometimes they just drool. Sometimes they get a bit of lip smacking, chewing, right? So all of those become, in some children, recurrent fevers could be the symptom of epilepsy. And sometimes recurrent abdominal pains could be the symptom of epilepsy. Recurrent leg pains could be the symptom of epilepsy. You know, headaches could be it. So it's quite difficult sometimes in children. And you only pick it up.
Diagnosis is also difficult.
So you pick it up because it persistently occurs. It occurs persistently, and then eventually, like you said earlier, that you go around the block a few times until the penny drops. You know, and then you diagnose it. So it's very important to understand that the symptoms of epilepsy in childhood are slightly different to the ones in adulthood. In the adulthood ones, we usually pick them up quite quickly.
All right. But I think the important point you made here is that having epilepsy in childhood does not necessarily mean that it's going to go on.
No, that's important because a lot of the symptoms, a lot of the epilepsies of childhood are actually benign.
All right.
And we need to accept that.
Let's just hold it there for a moment and go for a quick break, and we're back with you soon. Welcome back with our guest, Alexis Minar from IASA, Epilepsy Awareness South Africa, and of course, Prof. Girish Modi, specialist neurologist from Wits University. Now, Alexis, you yourself have epilepsy and you're diagnosed when you were quite young.
Yes.
Just tell us about when you were diagnosed with epilepsy and the circumstances around that.
I was first diagnosed with epilepsy at 9 months old. My mother was playing with me on the carpet and my eyes started vibrating, as she puts it, and I started shaking. So she took me in for tests and checks. And then later, when I was 2, I was diagnosed with tuberous sclerosis, which is a genetic condition, which has then caused my epilepsy.
Right.
Yes.
Right. And you've lived with epilepsy ever since, and you're still on treatment now?
Yes,
Okay, we're going to come back to... I mean, I think this leads us to then what causes epilepsy and what are the risk factors,
So about 2/3 of cases, we don't find the cause. So we get clever and call it idiopathic, right? We know that word very well, right? And then congenital disorders account for about 20%. And in the congenital disorders, it's usually absence of a corpus callosum, the bridge between the two hemispheres. It could be what we call migration disorders, where parts of the brain don't form properly. So instead of having the normal folded brain, you get a smooth brain. Or it could have little islands or pockets of nerve cells that have grown aberrantly. So these are mainly congenital developmental causes. As the baby is forming, in the fetus is forming, things go a bit wrong. We don't realize lots of things can go wrong, and we only know a small percentage of what goes wrong. And then the chromosomal disorders like tuberous sclerosis, neurofibromatosis, Sturge-Weber, where you get the port wine stain, you get an abnormal blood vessel in the brain that causes it. And so there are many of those congenital causes. And then there are causes such as trauma. So sometimes, you know, when you're doing the forceps delivery or the baby's small or a breech, you get trauma. Infections in our population have become quite important, you know, the birth-related infections or infections such as HIV that's then transmitted to the baby. Strokes, we sometimes see strokes in early childhood. And then, those are the main ones: trauma, infection, strokes. And those are some of the important causes. But the majority remains sort of relatively unknown. You get rare tumors that can also occur in childhood. But, you know, those you work out as you go along. So once you think of that group of causes, then you need to know what triggers the seizures and what brings it on.
Which is the next part I'd like us to come to. But in terms of your work now, just strictly around risk factors and causes, what's your experience there? I mean, in terms of, you know, how you interact with your people, what sort of questions you get around causes?
The personal questions I've received around causes have been things like...
But I mean, you interact with a lot of people and they
Yes,
come with
yes.
all sorts of questions.
Yes,
so
they
you
do.
do help them. And I guess you also take care of myths around epilepsy.
Oh,
yeah?
yes, absolutely.
Yeah.
My most dreaded myth is
Yeah.
when somebody has a tonic seizure
Right.
and, a grand mal seizure, and the first thing people want to do is put a pencil or
Yeah.
a ruler
clip.
or a
Yeah.
spoon in their mouth so that they don't.
Right.
The
right.
theory is that you swallow your
You're
tongue.
raising
but
a very
that's
important point. We're going to come
physically
back to that to
impossible.
say,
Yeah.
you know, what do you do when a child has, you know, epileptic seizures in front of you, you know? Let's come back to that issue that you raised earlier about triggers. Now.
Triggers, yeah.
You know, somebody is
yeah.
on treatment and, you know, what triggers
Quite
epileptic
important
seizures?
to know these triggers. So we spoke of one of the epilepsy syndromes, benign Rolandic epilepsy.
Yeah.
So this is a common one. So it occurs, for instance, the children usually get it at night. They're very brief, last 1 to 2 seconds, not more than a minute or two. And they can have all those things that we talked about, tonic, clonic, whatever. One of the big things that trigger there is light.
Okay.
So photic or photosensitive stimulus. And this is very important because we're in this generation of screen time.
Correct, yeah.
You know, I mean, we like have this fight with our children every day. How much screen time, you know? And in fact, I see the iPhones are sending you messages of how much screen time you did in a week.
Yeah.
So screen time is a very big thing, and people must get this right.
Yeah.
You know,
But okay,
it
we
can
know, I
trigger.
mean, our show is on television.
Yeah, I know,
and
I
television
understand.
as
But
well.
what I'm saying is, television is different to your mobile phone. It's different to the games you're watching and playing because the pixel emission to your brain is much closer, much stronger. And so, important photic stimuli. So that's a big trigger. Fever, we said, can trigger. Lack of sleep is a big trigger. And so children will often get nightmares and don't sleep well or are traumatized for some reason, school bullying, etc. They often find that as a trigger. And then hydration is very important in children. We don't realize it, but children and older adults are similar in the sense that hydration is a very important thing. And you know, the schools push them out in the sun, make them do basketball, baseball, whatever ball, and then the kids are not drinking water and then they collapse. And then finally, sugar. So you've got to maintain a diet that's important. So those are the main triggers.
Emotional status?
Emotional status is part of what we call stress. That can also be a serious trigger. And so it's part of this, you know, problems that they're either having at home or at school. They don't sleep well. So it all comes down to when you have all these emotional disturbances, you don't sleep well. And sleep is very important in general health, but especially in triggering of seizures.
So how well known is the fact around, you know, triggers? I would imagine they would be personal. Light, for instance, wouldn't be a trigger for everybody.
No. You get to know it. You know, I mean, the kids will come and they'll tell you that when they go from a room to a bright sun, they're going to have an attack or they go blank. And so you talk to the parents about it. It's all about education. And then from there, they pick it up. Sometimes you find the reflex triggers. So some children get reading epilepsy. And so I mean, that's a good excuse not to study. But, you know, when they're reading, they get seizures. Some get what we call micturition syncope or epilepsy and, you know, forceful urination. So you start, you know, working around this. Like the kids with the photic epilepsy, you give them the blue lenses to wear, glasses to wear. And there are various ways of doing it, not always to go straight into medication.
Alexis, do you know your triggers?
Yes. So because I have temporal lobe epilepsy, a lot of my triggers are caused from stress. So emotionally, I have to make sure that I don't get too angry in any situation or too excited in any situation. And then in terms of work, I have to make sure that I keep a healthy, balanced stress level.
So it sounds like you're in good control of, you know, the condition.
I've made sure that I've read up and studied myself and my triggers so that I can prevent going into a seizure.
Okay.
So I'm
Great
a
stuff.
studied teacher. I studied Montessori, and we work with 3 to 6 year olds. And it's a lot of high energy with little kids always running around and jumping around and getting very excited. And I had to come up with strategies so as to control my own excitement and my
Right.
own exercise levels and so
Right.
on and so forth.
Interesting.
Because,
All
yeah,
right.
it's a lot of high energy.
Okay. All right. Time for another quick break. When we come back, we'll continue our story. Please stay with us.
I have absent seizures just because I've got petit mal epilepsy, but it's all dependent really because my seizures come about from things like tiredness and illness and sort of been out on a late night out and things like that. So roughly I probably have about 4 or 5 a month, but they only last about a minute and a half. I wouldn't quite say it affects my day-to-day life just because apart from having to take medication morning and evening, I can do everything, like I'm in mainstream school and things like that. But as a whole, I can't learn to drive currently because of my seizures. Because I've had it from such a young age, I've sort of been able to deal with it and that's like normal to me, so it's not like I've had to adapt to having to not drive or not drink.
Epilepsy impacts young people in a variety of ways. All the time that they're having seizures, we have to remember that their brain is still developing. And for children and young people, there's loads of other things going on in their life. They have lots of issues that they're coping with, being part of a class at school, making friends, and relationships with their family and their peer group. Having epilepsy is just one more thing to cope with on top of lots of other issues. If somebody witnesses someone having a seizure, the most important thing to do is make sure that that person is safe. We don't recommend moving the person unless they're in imminent danger, such as near an open fire. Then we want to cradle the person's head, put something soft underneath it, cradle it in our hands, protect the head. And really you don't need to do much more than that. Make a note of the time so you know when it started, when it finished. We're working really hard in schools to bring up a generation of people who are talking openly about epilepsy and have an understanding of it, and they know how to keep somebody safe and they know how to include them in every activity that children like to do. Friendships are really important for any child, but particularly for a child with epilepsy, it's important that their friends are understanding it and are aware of the condition and know how to look after them if they need their help. Teenagers desperately want to be different in many respects, but they don't want to be different by having epilepsy. They need a peer group around them who can support them.
Okay, welcome back. We're still with our guest, Prof. Girish Modi, Head of Neurology at Wits University, Alexis Minar, Secretary of Epilepsy Awareness South Africa. We're now joined by somebody special, Nicolene John. Nicolene is mother to Naila. Naila is a 5-year-old girl who has been living with epilepsy for a while. Welcome to Health Talk, Nicolene.
Thank you very much. How are you, sir?
Good. Let's stay with you a little bit. Tell us a little bit about Naila.
Okay.
She's a bubbly 5-year-old.
Yeah,
I've just
she
seen her
is
around.
very hype.
Yeah.
Very bubbly.
When was
yes.
she diagnosed with epilepsy?
Naila was diagnosed with epilepsy in 2016.
Right.
When she was almost a year and a half. Naila was born in 2014.
Yeah.
Her first seizure was febrile. She
Yeah.
had a febrile convulsion which lasted about over 5 minutes, and we
Yeah.
rushed her to the hospital.
Yeah.
At Rahima Musa.
Yeah.
While they did all kinds of tests on her, they couldn't find what's wrong with Naila. So in 2016, I took her to Bara because we were closest to Baragwana.
Right.
So there they did a CT scan on her, which they didn't find any abnormal activity in Naila's brain. She did an EEG as well.
Yeah.
Everything came back negative.
Yeah.
But they diagnosed her with epilepsy when she was a year and a half. And yeah, since then she's been epileptic.
All right. Right.
Yeah.
Quite interesting, Prof. About diagnosis. She mentioned two important issues that we haven't touched on. How important is it to time how long a seizure or convulsion,
In
lasts?
terms of the diagnosis?
Well, generally, yeah.
But you see, in children, your seizures can last from seconds to minutes.
Yeah.
So sometimes, like the febrile convulsion can go on
Yeah.
up to 2 minutes. So you're never going to get a continuous seizure for more than that.
Yeah.
If it's that, then it's possibly a status where one seizure is
Yeah.
going into another, into another, into another without recovery.
Right.
That's a terrible situation.
Yeah.
But most of the seizures, and in childhood, most of the seizures are brief, very brief. If you take
Yeah.
benign prolentic epilepsy, couple of seconds. You take congenital absence epilepsy or any absence epilepsy, seconds is the answer. even the idiopathic, the generalized epilepsies in childhood, 1 to 2 minutes. You know, and quite common in terms of the seizure types in childhood are absences and myoclonic.
Right.
And the myoclonic usually alerts you. You can get a benign myoclonic epilepsy in childhood, but the myoclonic usually alerts you that there's an underlying problem.
All right.
You know.
Okay, let's come back to you then, Nicolene. I mean, so here you are, you're a mum. This is your third child?
That's my third.
Third child. And is the only child with epilepsy?
Yes.
So how did you take the news that you now have a child with epilepsy? What did it mean to you? Did it bother you at all, if any?
No, it didn't bother me, but it wasn't easy.
Right.
While we adapted to it.
Yeah.
It took time, but it's my child.
Yeah.
And she's special as well to us as the other two is.
Yeah.
And well,
Right.
we made peace with it.
And I mean, I'm not sure. I mean, she's only 5.
Yes.
Does she understand that she has this condition, epilepsy?
No.
She doesn't know.
No.
So your child is at preschool currently?
Yes.
And what's the situation there? I mean, have you made the teachers aware of, you know, the fact
She's
that
in
the
a
child has
special
epilepsy?
needs
Yeah?
preschool. She's in a special needs preschool, Sunshine Center. So she's with children that has epilepsy. There's children that has various types of disabilities. So
Right.
yeah.
Yes, sir. Well, I think it begs the question, I mean, is epilepsy a disability? I mean, is there a need for a child to go to a special needs
So
school?
it depends on the cause.
Yeah.
So if it's part of the congenital causes, or there was some trauma or some damage to the brain, then or a syndrome or congenital thing, then those children will have issues.
Yeah.
But even in the so-called benign epilepsies that I alluded to that don't go into childhood, they often have issues. Learning problems, attention problems, they are quite frequent in the childhood epilepsy syndromes.
Yeah.
So, and hyperactivity can be quite a common feature.
Right.
So, obviously when you see those, you're looking for abnormalities in the brain, you're looking for a syndrome, you're trying to match it so that, you know, you get the treatments.
Yeah.
But again, I have to emphasize, 2/3 of patients do very well.
Yeah.
It's that 1/3 that we struggle with, and we really do struggle with.
Yeah.
They are very poorly responsive to treatments.
Yeah.
And so sometimes, besides the medication, we even use the diets, the ketogenic diet that is quite popular.
Yeah.
It does help childhood epilepsies. We even use mechanical devices like vagal nerve stimulators.
Yeah.
And then in these very severe forms, I mean, surgery is quite often contemplated, where, you know, hemispherectomies, temporal lobectomies, removal of the focus, trying to, you know, stop the spread across the two hemispheres. You have to go to extremes to try and stop the seizures.
We're going to have to come
children.
back to those concepts a little later. But just going back to the issue of the school, I mean, a lot of parents or a lot of people ask the question, you know, are kids able to cope? You know,
if you take the 2/3, the ones which we call the benign epilepsies, like childhood absence epilepsy, or the benign Rolandic epilepsies, they do cope. They have a few learning issues, they have attention issues, but they cope.
Yeah.
Obvious, the majority of these children are not in special needs schools. Otherwise, we'd have a major special needs school demand, right?
Yeah.
So we're coping with that. So most of the kids are in general schools.
Yeah.
And they manage quite well.
Okay. Well, Alexis, I mean, you've lived through, and you're right at university now?
Yes, I'm studying a Bachelor of Arts degree.
Great stuff. So how did you cope with epilepsy in your childhood days, if you remember?
My teachers in primary school were very accommodating. However, after grade R, we couldn't have found a school who was willing to accommodate me. So my mother decided to homeschool me instead. And I think,
Yeah. So you had very good support at home.
Yes, I had a lot of support at home, and that was wonderful, and I've managed to pass matric and get to university and so on. But it's a big issue in South Africa with teachers and schools being too afraid to accommodate children with epilepsy because of lack of training or lack of knowledge. So it's puts a high demand on parents to educate the teachers when they send their kids to school. And unfortunately, in my first job, I had to witness a child being turned away from the school where I was working, and that was very heartbreaking for me because the teachers didn't even try.
Yeah.
They didn't ask questions, they didn't interview the mom, they just said, sorry, your child's not welcome here.
Yeah.
And
So I mean, it can be quite a scary thing, I suppose, for the
Yes.
teachers. And I suppose, you know, if they're not well trained
Exactly.
in the subject, you know, there's going to be all of these issues about
Yeah,
children
I
being
think
turned
it's
away.
the disruptions
Yeah,
that such a situation or event can occur.
yeah,
I mean, I was talking to a parent the other day, and she said the first time she saw it, she felt traumatized. She feels she needs counseling.
Mm.
And I said, because of the traumatic nature,
yeah,
it looks like something is happening,
yeah,
you know, something major. And
Yes.
yeah.
now it happens in a classroom, and it's not negative, but it does put everyone unease.
Yeah.
And then you know, it starts a whole ball of, will the person have it again? What will happen if they have it again?
Yeah.
And attention changes and shifts.
Yeah.
And teachers are barely coping with the normal functions.
Correct,
To
yeah.
cope with that, it puts a lot of
Yeah.
burden on them. I mean, even with knowledge, they battle.
Yeah,
Yeah.
yeah, yeah. All right, okay. Maybe it's a good point for us to break here. And yeah, when we come back, we talk treatment and everything associated with treatment of epilepsy. Please stay with us. Okay, welcome back, and thank you so much for staying with us. We'll continue our story on epilepsy, childhood epilepsy, and talk about treatment. Let's just talk about the principles of treatment, childhood
So there are,
epilepsy.
in childhood epilepsies, they differ from adult epilepsies in that your main treatment sources are medication, diet, mechanical devices, and then surgery. So they all play a role,
Yeah,
as opposed to in adults where medicines are the mainstay of treatment.
yeah. Is there any, so what's the goal in terms
The
of
goal
the
is
number of
seizure-free,
seizures?
obviously. The goal
Yeah.
is to control seizures.
Right.
The goal is to get you to a point where the child is now happy, the parents are happy, school's happy, you know, that
Yeah.
the child is seizure-free.
Yeah.
You do, in all the benign conditions, you do reach that point.
Okay.
You can reach it. There are many drugs, as you well know. I mean, the older ones like phenytoin we hardly use. Sometimes you have to use it. Phenobarbital, which is the oldest of all the
Yeah.
drugs. Sometimes you sort of have to use it as a rescue.
Yeah.
Still available.
Yeah.
Then valproate. And then we have the newer ones, lamotrigine,
Yeah.
topiramate. We have
So a whole lot of
levericetam, lots
Yeah.
of them now.
Yeah, yeah.
And then we also have, for the some of the special syndromes like Lennox-Gastaut, we sometimes, or the infantile spasms, the different early childhood epilepsies, we often sometimes use steroids in them
Yeah.
to assist with the medication.
Yeah.
And we also have certain other drugs that are peculiar to childhood epilepsies,
Yeah.
Sabril and various other ones that you would never think of using in adults.
Okay. So
So
how
it's
is how is treatment monitored then?
So monitoring of treatment is again the same thing. Principles of treatment are: one, seizure-free. You can use the EEG to assist you in terms of monitoring, and that's about it.
Okay. So in children, I mean, do they do these blood levels to determine
Oh
the
We
doses?
do blood levels. You have to do liver tests.
Yeah.
Because some of the drugs are quite toxic. We used to have ethosuximide, which we use quite a lot for absence epilepsy.
Yeah.
It hits the liver a bit, so you
Yeah.
have to monitor these drugs.
Yeah. Yeah.
So also in this country, availability of the drugs is becoming an issue.
Yeah.
And often you find the ones you want to use are not available.
Yeah.
So that's something important. You do always do therapeutic levels. You always do a liver test. You
Right.
measure ammonia levels, because some of these drugs increase ammonia in the brain, and then they can also trigger seizures.
Okay.
So
Nicolene, just take us through your experience with Naila in terms of the treatment that she's been through.
Okay. So firstly, Naila, let me just say, when she was much younger, when she started having her seizures, she had them quite a lot, like maybe in a week 2 times or 3 times. But when she grew up a bit, it's a bit controlled now. So she'll have it like once a month or twice a month,
Yeah.
or she'll have it after 2 months now.
Yeah.
So with treatment, now Ella started on Epilum,
Yeah.
which they started on 3 mils,
Yeah.
and then so it increased as time went on.
Yeah.
So now she's on 5 mils Epilum 3 times a day. They introduced a pyramid as well, which she gets in the morning
Yeah.
and at night.
Right.
So yeah,
And is she seizure free currently?
she's not.
And how many does she get?
Let's say last week Saturday, she was hospitalized because she had a breakthrough seizure,
Yeah.
which lasted, well, like the professor said earlier, she had one, but then I think she comes out of it and she goes into one again. So it was like almost like 30 minutes into it. So when we took her to the hospital, she was out of it, but when we were on our way, she went into it again. So she was admitted at Ward 31. They always take her blood to see
Yeah.
if the levels is correct in her system.
Right, right.
So she overnight, and then the Sunday she was discharged. So unfortunately I wasn't with her. My husband was with her because I had to go to work on
Right,
Sunday.
right.
So they discharged her, but the Epilum level wasn't there yet. So
Right.
on Monday, my husband went back to the hospital to find out what the result is. So unfortunately, they say it's low. So
The
I
level
don't-
is low.
The level is low. So I
Right.
don't understand, because they ask us if we do give the medication. I keep with my medication every day, 3 times a day Epilum, 2 times for a tablet. So I also don't understand
Yeah.
why the level
Yeah.
is always low.
Do you want to perhaps comment on that? I mean, it's
Yeah, it could be a metabolism issue. You get sometimes fast metabolizes, and so the epilum may have to be changed. You also don't want to go too high in the
Yes.
doses, then you get other side effects. And that's the other thing when you're talking of treatments we have to be very wary of in children,
Yeah.
is the side effects.
Yeah. What
So-
sort of side effects?
So drowsiness, sedation, interference with learning, attention issues also. Sometimes valproate can make you quite hyperactive as well. And so they become part of a bigger problem than in adults because of the schooling issues.
Yeah.
So, you can't go to a school and spend half your time sleeping,
Yeah, yeah.
because you're overdosed or overdrugged.
Yeah.
So one has to be wary of all of this. And so if you get a patient like your child where the levels are persistently low, it might be better to just change to something else.
To something else. Okay.
Because they did also, because she got the Epilum 3 times a day, 5 mils. So now it's in the morning 5 mils, and then in the afternoon she has to get 6, and then at night 5 mils. So they just
They
upped it
made
a
an
little bit in
adjustment.
the middle
Yeah.
to see.
Yeah. How about you, Alexis? What treatment did you go through?
I've been on Tegretol since I was diagnosed. It seemed to have worked very well. And then when I hit puberty, unfortunately, my epilepsy completely freaked out. I was having 20 seizures a day, in and out, barely able to cope. It did put me in a type of trance. I was kind of in my own little world, and I didn't communicate with my parents or my siblings at all. At which point, my pediatric neurologist started going through the list of treatments, and my body rejected just about everything except for the Tegretol. After 2 years, so I was having these seizures from the age of 10 till the age of 12. My neurologist finally decided to try Keppra, which had only been tested in the States and had just come to South Africa, and it had only been tested on adults. It had not been tested on children. Fortunately, I was the correct weight, and it worked. And so I've been on Tegretol and Keppra ever since. Just depending on my weight and the activities that I do during the day, the levels fluctuate, so they go up and down. If I gain weight, the level has to come up. If I lose weight, the level has to go down, just to maintain balance. But at the moment, everything seems very well balanced.
Is it? Yeah.
Yeah.
Yeah. I mean, this issue of, what is reasonable, and of course, maybe that's not the
Reasonable
right way
control.
of. Yes, in terms of how many seizures. I mean, if you're saying, okay, my child had 2 seizures in the last month. You know, what is reasonable, what is not reasonable?
Yeah, I think 0 is reasonable,
Yeah, yeah.
Yes.
but not ideal.
Right.
So, I mean, it's not right to say it, but we do work on that basis that if you have 1 seizure a month, we could tolerate it.
Right.
I wouldn't say acceptable.
Yeah.
Yes.
Like I said, the word is tolerated.
Right. Right.
Because, you know, every time you have a seizure, you don't know what it's doing to your brain.
Well,
We
this is the
assume,
question. This is the
we
question.
assume.
Is there any form of
Yeah.
brain damage with
Well,
every seizure?
Well, we know, and the evidence points to the following, that brain damage will only occur if you have recurrent seizures from which you do not recover, the status. So if you go from 1 seizure to the next, to the next, to the next, without recovery, your chances and your risk of brain damage are very high. Just a single seizure, there's no evidence that you have brain damage.
Right.
But that evidence in terms of whether it affects a little bit of cognition, a little bit of attention, it's difficult to ascertain. So we don't like to have seizures.
Yeah.
As clinicians, we try our best to make sure patients are seizure-free.
Yeah.
But sometimes that's difficult, especially in that group of epilepsies, which we call the intractable ones, the ones with all the issues. They are very difficult to treat. You sometimes not just on 1 pill, you're on 2 different drugs,
Yeah.
3 different drugs,
Yeah.
and you still struggle with control.
Yeah. And I suppose in closing, support is quite important
Yes.
from your
Yes.
families. Last 30 seconds, you're getting great support from your family and everybody around you?
Great support. My mum,
Yeah.
my dad, my sisters, my husband,
Yeah.
siblings, everyone.
And Alexis?
100%.
Yes, we get a lot of support at
Yeah.
home. It took a long while for our family to accept the condition and the
Yeah.
epilepsy, especially my grandfather.
Right.
But now that I'm older, we get a lot of support, especially from my husband. My brothers are very supportive.
Yeah. Great stuff. That's where, I'm afraid that's where we're going to have to leave
Right.
it. And I want to thank you so much for your time and I wish you all of the best. And thank you to you, Prof.
Thank you.
Right. And to you guys at home, thank you so much for staying with us. We're back with you again in a week's time. Same time, same place. And until then, please do take care.